So welcome everybody. We will start with 1 minute before the official start of the session. So this will maybe attract people discussing just behind the door. So I'm very happy to be here and to welcome you on this 3M symposium. And it will be targeted at some important and quite recent important aspect to reduce the infection risk, and we will concentrate on the access points. Some preliminary remarks. You have found on your chair not only the detailed program of the session and some biography of the speakers, but you also receive a card with a pen, and we will ask you to write the questions, because we will not have questions at the end of the 3 presentations. We will have questions and discussions at the end of the session. And do not hesitate to ask questions, because for the question who will not be able to be answered during the session, we have decided with 3M to put the question and the answers on the website of the WoCoVA. There will be a special page for the 3M satellite, and so you will be able to find the answer the speakers will be able to give after the session. So then I will go on with the introduction. How big is the problem of catheter-related infections? We know from these ICU prevalence study performed about 10 years ago, led by Jean-Louis Vincent. It was all around the world. We see that first, half of the patients being in ICU had an infection. And about 2/3 of these infections were nosocomial infection. And among these infections, 15% were bloodstream infections, and about 5% could probably be attributed to microbiologically documented catheter-related infections. So it fits the size of the problem. These are not the most important infections, but you know, this is probably why you are here, that probably they are the most preventable nosocomial infection. The mortality rate is probably around 10%, and it's very interesting because it's also the rate of attributable mortality for respiratory infection. But I think that according to the frequency of use of the IV access, these mortality rates is really very important to consider, because I think that it's itself justify all the efforts we made, and it also justify probably the investments that are nowadays required in terms of healthcare personnel time, and also in terms of amount of money required to buy and to use devices. So here the next one. And reducing the infection risk at all access to the device and to the lines connected to the line, so the port, is very important. It has been shown, and these data come from studies 20 years ago, that the extraluminal contamination of the device may represent 60% of the source of the infection. But with time and with prolonged catheterization time, the intraluminal colonization of the biofilm is also important, and this emphasizes the importance to do something at the port, because it was demonstrated, we show many years ago, that for an ICU patients with central venous lines and arterial lines, we may have more than 100 opening of the ports every day. So it's a huge amount of colonization, and then maybe in catheter-related infections. So here is the agenda. We will have 3 parts. And I think it's very interesting to see that we should view that as a whole concept, really to try to capture and to put importance at several things. So it's also, like the bundles, a multimodal approach to try to protect this seat of insertion. So here is the introduction for the first speakers. You have his short biography in the presentation. I will not spend more time on this, and I invite him to take the floor and to start with the first presentation. Thank you.
So hi, my name's James. I am the lead IV nurse for infection control at UCLH. I'm looking at a blank screen. Oh. It's gone right back to the beginning. Okay. So this is where I work. We are a large central London hospital. The building there is our main site. We're actually split over about 6 hospitals and over 8 different sites. We see over 1,200 inpatient beds. We see over 1 million outpatients, and a lot of those patients now are having vascular access devices. We have just under 160,000 inpatient admissions, over 120,000 A&E attendances, and we have lots of different specialities, particular neurology, neurosurgery, hematology and oncology. We also have more than 50 ITU beds and a very large level 3 neonatal unit. What I'm going to be talking about is protecting the insertion site. So obviously one of the main ways we do this, or the main way we do this with a bundle to prevent harm, particularly with the ongoing care of lines. So this is our care bundle. It does look quite long, but we've added over the years different bits. We've added sutureless securement into it. We've also added CHG dressings into it over the years. So it's gradually built up over the years, and as the evidence has changed over the years, we've added additional bits to it. So why do we need some of the adjuncts to care bundles? Particularly patient groups, particularly patients with neutropenia, patients with dry or damaged skin. We know that they have more Staph aureus, that it will be on their skin as well. And also some of the other issues with our staff, compliance with the bundles. We have a high staff turnover, so we're continually trying to educate and update people on the care of IV devices as well. So we've introduced the Tegaderm CHG in 2010, so we've used it for over 6 years now. And as you can see, particularly with our MRSA rate, it's been very effective at reducing it. This was the main reason how we justified the extra expense of going to a CHG dressing. We've also seen some reductions in our MSSA bacteremia. We do still see some MSSA bacteremias with patients with IV lines. We have reduced that. We're particularly now seeing them, MSSA bacteremias in patients with IV lines when they've had an IV device for over 2 weeks. So we've actually reduced it down to about 25% that we believe that's related to the ongoing care now since we've introduced. But we do still see lots of other causes of MSSA bacteremias. So Tegaderm CHG, we've used it for many years. We think it is really effective at reducing our bacteremia rate. We insert as a trust we reckon about 5,000 IV, long-term IV devices from MIDS to PICS to Hickman lines. So we do use it on the vast majority of our patients. We have over a 98% compliance rate with Tegaderm CHG, with some variances for particularly if they have a known allergy to CHG. It's also been added to, Tegaderm CHG has been included now into our EPIC guidance. And it was evaluated by the National Institute of Clinical Excellence last year. So they evaluated Tegaderm CHG. They concluded it offered better protection than non-CHG dressings. It has comparable efficacy with CHG impregnated sponge. In it, they reviewed the two Tismet papers, which found there was a significant reduction in CRBSI. So we evaluated it about 6 years ago now. We evaluated it in all of our intensive care units for use on all of our CVC lines. We also used it on our oncology unit over 30 days. We received evaluations back from 36 members of staff. We looked at particularly around the ease of application of the dressing, time taken to apply the dressing, ability to visualize the IV insertion site during use, the ability to absorb fluid, including blood and exudate, the ability of the gel to conform and fixate to the catheter, the ease of removal of the dressing, and the condition of the skin removal after removal, and what the clinicians thought was the overall performance of the dressings. So some of the findings, the nurses in particular liked that they could see the site, and a lot of the patients also commented, and still do comment, that they like to be able to see their insertion site so they can spot any signs of early signs of infection. The nurses really liked that it was a one-stage process when it came to changing the dressing. In fact, they felt it was much simpler and easier for them to change. We did have issues of dislodgement when changing the dressing, and it was cost neutral for us because we were using a CHG sponge, and we managed to actually save a little bit of money for our trust. So some of the considerations when using Tegaderm CHG, it can absorb quite a lot of fluid, but it's something that you need to keep an eye on and change it when the CHG gel has absorbed a lot of fluid. The CHG Accent still works when there is blood or fluid present. You do get some patients who are sensitized to it or possibly can have an allergic reaction. However, when NICE did their evaluation, they looked at a 2-year period, and they only found one adverse event in the UK. and there were over 600,000 dressings supplied. So it is a very safe dressing to use. One of the important things is that the nurses or whoever changes the dressings leaves the skin prep to dry on the skin and allow it to make sure the alcohol is fully dried before applying the dressing over the top. And particularly the training is crucial for the application and removal of the dressing. So this is one of our cardiac ITU unit that's now actually moved to a different trust. Particularly when they trialled it, they were very reluctant to do any changes, even though they had lots of CVC lines that were dislodged during their stay on the ITU. It was particularly associated with patients who were sweaty, who were clammy, and that was one of the factors that was felt that was leading to the dressings falling off and the lines falling out. And standard practice in the unit was to suture lines in place. As I said, the anaesthetic staff were very reluctant to change their current practice. They did like to suture lines in at the time. They fear that there was going to be patient harm that was going to happen when lines became dislodged. We gave lots of training on the unit, and towards the end of the evaluation period, the actual anaesthetist decided, we don't want to change, we don't want to go back to the previous dressings that we were using. And they found that the CHG pad actually provided extra security and stability of the lines as well. And no lines were dislodged during the month's trial. So some of the conclusions, Tegaderm CHG has been successfully trialled, is now the standard IV dressings, and we do have over 98% compliance with all our line dressings from over 16-year-olds in all of our patients with all long-term devices. Training really is crucial, and make sure the nurses are aware of the importance, particularly when they're removing lines, and it has been positively reviewed by NICE and EPIC now. Okay. And that should be me. Done.
Okay, thank you for this wonderful review of the skin insertion site. Now, maybe we will sit there later on when we will discussing, but if you don't stay here, you will not see the presentation from the next speaker. So remember, for those who arrive late after the beginning of the session, you will find on your chair a sheet of paper and a pen. Please write questions, and we will try to answer to the questions. And again, for the question not possible to be answered during the session, we will put them with answers on the website of the WoCoVA 3M Symposium. So I now ask the second speaker to come. So we move a little bit along the device, along the catheter, and he will speak from another important point.
Okay, thank you, Philippe. Hello, everybody. Okay, so I will discuss about to-stitch or not to-stitch short-term CVCs, and probably Shakespeare would have said that is the question. I'm not sure that is the question, but probably is one of the questions we have today about how to secure this kind of catheter. So first of all, I would like to thank the organizing committee and 3M to invite me to do this talk, and before starting, I will just show you my disclosure. Okay, so as previously said by Philippe, we know that catheter routine infection remains one of the most important causes of healthcare-associated infection, especially in the ICU, and those kind of infection increase loss, mortality, and cost. And this is probably the best model of nosocomial infection that can be avoidable by improving patient care, especially by developing technical as well as socio-adaptive strategies. And among these technical strategies, we can propose the use of sutureless circumvention devices instead of using the classical sutures, which remain probably the most frequent technique used to secure the catheter in the ICU. Why to use sutureless circumvention devices? Because this kind of device have the theoretical potential advantages to reduce infection by two-way, preventing catheter displacement, and also avoiding skin injury around the catheter entry site. But these kind of devices have also other advantages. First of all, it's probably safer for healthcare providers by reducing inadvertent needle stick injuries. It may improve patient comfort by also reducing skin disruption. And finally, and unfortunately, there is very few limited evidence in the literature evaluating this kind of device compared to sutures. This is why we decided to conduct a pilot study, which was a multi-center study, prospective one, observational, randomized, and blind clinical evaluation of two kinds of securement in the ICU. One sutureless device, and we use the 3M PIC CVC securement device, compared to sutures for securing short-term CVCs in critically ill patients. In this study, we include adult patients admitted to one of the 4 participating critical ICU and requiring a single short-term non-cuff, non-tunnel CVC, which at size lower or equal to 12 French. And we also need to obtain consent from the patient or their relatives before starting the study. Exclusion criteria include confused patients, patients having excessive perspiring, patients having condition affecting the skin integrity at catheter insertion sites, such as burn, for example. Also, patients having incorrect bleeding diastasis, allergy to adhesive or the device component, patients requiring more than one catheter inserting at the same location, and finally, patients having previously included in the study. Each of the 4 centers need to include 42 CVCs, and we stratified according to the insertion site, so 14 for the internal jugular vein, 14 for the subclavian vein, and 14 for the femoral vein, and then patients were randomized, say 7 catheter in the control group and 7 catheter in the intervention group for each location. The control group was the use of sutures plus the advanced highly adhesive dressing from 3M, and the intervention group, we use the 3M catheter securement device plus the same dressing. And it was planned before starting the study that dressings should be changed every 7 days according to the manufacturer recommendation in case of the catheter which stay in place for more than 7 days. This is the device we use. The device is on the market in the US for more than 3 days, but it's also available in Europe. And it consists of, I don't know if I have a pointer. Yes, it consists of here the mold plastic device integrated onto a breathable base with a silicone adhesive, which allow for the to secure the catheter, and we use this highly adhesive transparent dressing. And this kind of dressing allow for the securement of all catheter of central venous catheters having a size lower or equal to 12 French. This is the preliminary results on about 100 patients. And as you can see, this is a characteristic of the patients. There is no difference between groups. Most of the patients were male and with a median age of more than 60 years. And as you can see, relatively severe with a median FPG2 higher than 20. This slide shows you the main characteristic of the include central venous catheters. First of all, as you can see, most of the catheters were included in the internal jugular vein or the subclavian vein, and less in the femoral vein. This was because two participating centers have some difficulties to include the, catheters for this route because this is not routine in their unit to use this kind of route, and this is why we have less catheter in the femoral route. Most of the catheter were inserted in the right side. Surprisingly, less patients had their hair removed at insertion site with a securement device compared to sutures. We expect the difference. And when we compare time to insert CVCs, always as the time catheter remain in place, as you can see, there is very few differences. Maybe a trend with prolonged time with the intervention group. This is the primary endpoint, so we did not perform statistical analysis because it's just for show you the first data, but this is just descriptive data, but without any statistical analysis. The first line shows you the daily CVC movement according to groups, and as you can see, there is no difference. With, for the two groups, no movement observed according to the secure technique we use. And the second line is the total catheter movement. That is the movement between the day of insertion, still the day of catheter removal, and again, very few difference between the two groups, maybe a trend to a higher value in the intervention group, but the difference is minor. It's 1 millimeter compared to 2. Just note that in some patients, we have a large difference, 3 centimeters in the suture groups and 2.5 centimeters in the securement system group. Oh. Secondary endpoints. Time to apply catheter securement including dressing were similar between the two groups. Time to replace catheter securement including dressing was higher in the intervention group, and this is probably because in this group, nurses were asked to change also the securement device, and changing the securement device is, especially when it's relatively new for you, takes time because nurses were afraid that the catheter are not secure during this period, so there is a risk of catheter dislodgement. So this is probably why it took more time than in the suture groups. By contrast, time to remove the securement system was shorter in the intervention group compared to the control group. Erythema at dressing replacement was lower in the intervention group. Nurses were asked to know if they find easy or not the replacement of the securement system and dressing. For 100%, it was easy in the suture group compared to 82% in the intervention group. They were also asked for the same information but at catheter removal, and again it was 100% in the suture groups and close to 100% in the securement system group. And finally, we use a score, a pain score from 0 to 5, according to the modification of the face of the patient during the system and dressing removal. And as you can see, the level was at the medial value at 1 in the suture group compared to 0 in the securement system group, so, a value which is slightly lower in the intervention group. Other points, in one patient in the sutureless device group, we observe a complete dislodgement with a catheter insert in the internal jugular vein during the dressing change, but it was observed in a patient, in an awake patient, who take his own catheter with his hand. So I'm not sure that if the patient have also sutures, the catheter will also probably completely dislodge. And some nurses also, some physicians observe also some difficulties when catheter was inserted in the internal jugular vein, especially with the anterior root, in male having hair and beard, because in those cases it may reduce adhesiveness of the sutureless device. So to conclude this preliminary data, what we can say, probably we can say at that time, but should be confirmed at the end of the pilot study, that this new device first remain in place up to 7 days in most patients without spontaneous removal. So it's interesting first, because we know that in most cases in the ICU, due to perspiring, we need to change dressing before the 7 days. So this was probably an important point. The point is that we do not observe any difference regarding the time to apply the device compared to sutures, and probably removal seemed quicker. Also, sutures were more painful for the patients. And finally, the sutureless device was overall well accepted by healthcare provider after being adequately trained. So I think that with appropriate training, maybe sutureless securement systems will offer a safe and effective alternative to the sutures, which is actually the way we use to secure our catheters in the ICU, but larger study on both efficacy and safety of these alternative CVC securement systems are needed before definitely conclude this point. And just thanks for the different people working for this study, the Professor Tom Elliott, which is investigator-in-chief of the study, Dr. Tarja Karpanen, which is a study coordinator and performs the analysis I show you, and the 4 centers of the study from UK, Spain, 2 in France, and finally, thanks for 3M to support this study. Thank you.
So thank you, Olivier, for this very nice presentation of this very promising solution to fix the catheter. Please remember that we are waiting from your written questions on the white cards you receive. And now it's my pleasure to ask to the third speakers to come, and please, Corinne, share with us your experience.
Thank you. I'd like to thank 3M for the opportunity to present the study, and also the Congress for accepting the study as well. This study was undertaken at Barking, Havering and Redbridge University Hospital by the Infection Prevention and Control team, and it was an audit of port protectors in clinical practice. And I've got the same problem. So we're going to look at the introduction, so we're going to look at the study rationale, the methodology, results and conclusions. As we're all aware in this room, current practice is active disinfection or scrub the hub, and this relies on a 15-second scrub and a 30-second dry or kill time. Passive disinfection is a preloaded 70% isopropyl alcohol port, which requires 3 minutes to deliver a 5-log reduction and can stay on for up to 7 days or until the next access. As we know, international guidance for device disinfection relies broadly on 3 factors: the cleaning technique that the clinician uses, the duration of the physical cleaning, and the duration of the disinfectant drying kill time. So why did we want to actually do an audit of Curos? We knew that in our trust we had a higher than average bloodstream infection rate. We were aware that there was non-compliance with Scrub the Hub. It's virtually impossible to audit Scrub the Hub unless you're physically standing with the person who's actually doing it at the time. Curos basically designs out or engineers out the human variation. The only British evidence for Curos was by Mia Small when she undertook a study on home potential nutrition on oncology patients. However, there has been a large proportion of USA peer-reviewed studies. We wanted to know if using Curos would improve compliance with port cleaning. We also wanted to know, would there be a positive or negative effect on line-related rates with passive port decontamination. So we undertook a 6-month cross-site study. We used 4 wards. We used an oncology ward, acute care of the elderly, one of our adult intensive care areas, and a surgical ward. All of these areas had high to medium to high use of intravascular lines, and prior to starting the study, the users completed a questionnaire on usability. So we did a retrospective review of the ward's BSI data for 6 months prior to, and we also did the data for the 6 months during the trial, and we did a washout of 6 months data post the intervention. All staff who used the Curos were trained prior to the introduction. We also removed the intravascular disinfection wipes from the area so that nobody had access to them. And we undertook monthly compliance audits during the study. So we did a pre-survey of the Scrub the Hub and what port cleaning the staff were doing. And we sent out, we had 104 responses from staff, not just from the 4 areas that were being used, but from a wider area throughout the hospital. And we benchmarked this against the national data that had been done. So what we found that we were comparable with national data for staff actually scrubbing the hub for 10 seconds or less. So that was 54%. However, for drying time, we actually were worse than had been recorded by the national data. So the national data was 63%, and our data showed that staff were actually allowing it to dry 25 seconds or less for 75% of the time, which actually was putting our patients at quite a risk. What we found was that if there was a compliance rate of 80%, then we actually had a reduction in our bacteremia rates. So we had a 53% higher compliance rate with the Curos than Scrub the Hub. On the 4 departments, we measured the, as I said, we measured the BSIs for 6 months prior to, and we had 26 throughout the 4 departments. Acute care of the elderly had 0, and we used them as a benchmark throughout the trial. So during the intervention, our BSI rates went down to 8. So we did a 69% reduction in our bloodstream infection rates from intravascular devices. So this is this shows you it in graph format. So the green by itself, let's see if we can get the pointer to work. We don't know which is the pointer. So the pre-intervention period shows you our BSI rates, and the blue, oh, you've got really point, oh, okay. So the blue is the audits, the monthly audits, and what it showed, I mean, we had a dramatic decrease, and what it was showing was any time it dropped below 80%, we had a spike in our bloodstream infection rates for intravascular devices. And we had a mean reduction of 1.5. And this is the washout phase. So what happened once the Curos was removed, and I say again, I can't do it. Oops. There we go. We suddenly started seeing spikes back in our BSI rates. So we looked at bed saving and product comparison. So what we found was that using the 15 seconds and 30 seconds drying time and extrapolating that, we actually saved 330 clinical hours throughout the trial. And using 11 days as a benchmark, we calculated that we saved 198 block bed days. The total spend for the product was just under £7,000 versus just under £700 if we had been using the disinfection wipes. So you can see why at times people would want to use them, because it is a lot cheaper. However, if using international data to work out our costings, we actually saved a potential saving of just under £300,000 if it was central lines, and just over £100,000 if it was peripheral lines. Once the study was completed, 76 of the nurses who had been using the Curos were asked to do an anonymous feedback, and we got a 70% return rate, which is pretty good. And as you can see there, it was 100% for ease of use, more effective, improves patient outcomes, visually auditable, received training, and wanted to continue to use the product. There was 1,094 patients who actually had Curos applied during the 6 months, and that worked out at 27,000 Curos that was applied during the 6-month period. The patients loved it. They loved the visibility of Curos. They knew when the device had to be changed. If anybody walked away from them without putting their little green hub on, they basically said, "Oi, where is it? We want it." So, it made them feel safe, and they felt that they were in partnership with their care. So conclusions. We felt that Curos could deliver a higher compliance to hospital cleaning policy than Scrub the Hab. It's much more easily auditable. Green means clean. So if you walk onto a ward of 30 beds and half of those patients have got an intravascular device in situ, if they haven't got a green hub in it, they fail the audit. Simple. We saw the increase in BSIs after the Curos was removed, which suggested that the Scrub Rehab is less likely to be complied with versus the Curos. We felt significant financial savings could be achieved with Curos using a spend to save approach. Clinicians' time could be freed up. Also, further research into saving of clinical time is required. There was a high patient and clinical engagement with Curos versus Scrub the Hab. And Curos, we felt, could deliver a significant improvement over Scrub the Hab in the fight against CRBSIs and the aim at zero infections. And also, the final one there, we feel Curos is a small change that makes a very big difference to patients and their outcomes. And I'd like to take the opportunity to thank my colleagues at BHR who helped undertaking this study, both on the wards and in my own team. So thank you.
Okay, thank you for this wonderful review of your experience. So I will ask now the speakers to join the podium, and we will start with the answer to the question I received. as they are taking the chair, I will answer to the first question we received through an emails to before the session, and the question was, how can we effectively establish the value of education with infection prevention in terms of economic value of evaluation? I will answer briefly to that effectively in science we should really try to study every component and to try to show if it's cost effective or not. So this could be difficult with a multimodal approach, but I think that at the end, we all know that if we avoid 1 or 2 infections, I think that we will get the money back for all the program we will launch. And I think that I'm much more optimistic on this point. Now, thank you for the question. I will start here with the first question, which was for you, James. What is your experience with adhesiveness of the Tegaderm CHG on sweaty patients? What do you do to make it stick to the skin?
We find it's been very good for particularly any patients who are clammy or sweaty. I mean, one of the key things is using the skin prep and leaving it to dry. Sometimes we will use a skin barrier as well for those patients. That's what we tend to find that works.
Okay, Olivier, what is your experience in this specific field?
Yes, it's the same. We observe a better capacity to adhere to skin, even in the ICU patient. We know that most of the case because of perspiring, because of fever, a lot of reasons that induce the dressing change sometime once or twice a day, which was not the case with this new dressing. So my nurses were very interesting by using this product, which is clearly more efficient in terms of adhesiveness. Mm-hmm.
Okay, thank you. And Corinne, did you have some experience with that?
I don't. I'm the
okay.
strange one in the pile. I'm an infection control nurse, not a vascular access nurse, so I don't really deal with that side of it.
Okay.
Sorry.
Thank you. I think it's an important point from a practical point of view because, Olivier, you have shown with your French colleague that the number of change of the dressings has an impact on the further rate of infection. And so anything that is possible to do to try to avoid change could be viewed as positive. And in this line, I think that the new technologies bring and with these dressings could be very interesting. Another question to James and maybe also to Olivier. What dressing do you apply on bleeding insertion sites? Very common.
We tend to use glue, particularly for our picks and midlines, which we find in most cases will stop any bleeding. For the odd patient who is persistently bleeding, usually because they're on anticoagulants, we use an alginate dressing and then a Tegaderm dressing for a few days until the bleeding stops.
We use gauzes and try to stop hemorrhage by compression. So usually it works, but sometimes I know that it can be complicated. And as you know, when the anthracite is bleeding, probably you increase the risk of infection because blood is very good for bacteria. So.
Interestingly, are you using disinfected devices with the cost associated to this device when the insertion site is visibly bleeding, or do you wait that the bleeding has been stopped?
We try and wait till the bleeding stopped before putting a Tegaderm CHG on.
I I think that we can use gauzes just before the dressing, because probably we can expect some diffusion of the antiseptic through the gauze, and probably have some effect on skin. So I'm not sure that I will change the kind of dressing even in the bleeding patient.
Okay, we have the same experience when patients are coming just after the insertion and there is an active bleeding. We try not to use 10 Tigaderm CSJ during the first day, and I think that it should be viewed that the continuous release of the chlorhexidine should be viewed on the middle term, so on several days. And so at the beginning, in any case, these are not good patients, but we have to deal with these patients in any case. So a question also for James here. Do you see patients during admission with carbapenemas or with, I think, I read with resistant, with gram-negatives also, not only Staphylococcus?
Yes, we do. We actually take patients from all over the world. We particularly take patients from Malta and Gibraltar as well, particularly in our neuro unit. So we do actively screen any patient that comes from a high-risk hospital for gram-negatives, for resistant gram-negatives. And also any high-risk hospitals, because there's some high-risk hospitals in London, we'll also screen them as well.
So we have a chance in my hospital to have very few patients that are colonized with multiple resistant pathogens. So, and for patients at high risk, we sample them at entry just to look for any colonization. And fortunately, it was very few patients, even when they are at high risk, that are actually colonized. So we have the chance. I don't know if it will continue with time, but today, at least, this is not our major problem.
Okay, Corinne, do you also have this problem in oncology wards?
Yeah, we have, a bit like James, we have a large population coming from London hospitals who have got issues, but also we have a large neuro unit, so we take patients from quite far away, and we actively screen for the sort of high-risk gram-negatives, and we will isolate those patients until we get the results back.
Okay. Now, it's an increasing problem, as it was presented by Ricardo during the opening session. In some hospitals, we may have a higher proportion of gram-negatives responsible for catheter-associated and related infection. But I think that conceptually, all what we have discussed should also work to protect against any microorganism, even if from a microbiological point of view, it could be possible to show that there may be some differences. But I think that all these efforts should conceptually be efficacious for all types of infection. The next question is maybe for Olivier. Can anyone share information of the use of sutureless fixation device in baby or neonates with no neck?
I have no baby and no neonates in my unit, fortunately. I'm just working in an adult ICU. I think that today, I don't know exactly know, but I'm not sure that there is specific device for babies. So maybe in the future, companies will develop this kind of product, but to the best of my knowledge, there is no product for babies.
James or Corinne?
I don't. Yeah, it's a problem on our neonatal unit, and particularly we haven't found a device for that we could use on the neonate. So it's definitely something that we could use.
Yeah, we don't.
Okay, in the audience, is there somebody who has experience with this device on babies, neonates? Please raise your hands. No? Could we imagine to use that on the thorax of small babies? Maybe. Yes? You think so? Ah, okay. I totally do. Okay, okay. Now, I think that we have wonderful new devices, and I think that it should be discussed how could we integrate these devices in our practice, and how can we adapt these to our special case mix of patients, being newborns, neonate, for me burns patients, because with burn patients it's always difficult, and most parts of the bundles do not work on burn patients, so it's very interesting. And I think I agree with you, Olivier, we should also maybe ask for new devices and more specifically targeted to special subpopulation of patients. If you have question in the audience, please raise the hand. We will also take this question. So the next question is there an evidence to replace the device under the dressing every 7 days? Do you have microbiological data?
To change the securement device,
Yes.
under the dressing, this is a question, not the dressing.
Yeah, the securement, I think it was related to the securement
because
device.
for the dressings, we have data comparing 3 and 7 days. We did this study with Jean-François Timsit some years ago, and we show that 7 days was as efficient as 3 days. So, and maybe 10 days is the same, but we have no data on that. Concerning the securement device, to the best of my knowledge, there is no data, no scientific data indicating that this device should be changed every 7 days. I don't know why 7 days has been chosen, maybe because 7 days is 1 week, but why not 30 days? Because 30 days is sometimes 1 month, so I think that is probably, but the company can also answer this question, is probably a recommendation from the FDA that probably asks for the company how long time this kind of device can stay in place, and probably they decided 7 days because 7 days is 1 week. But and if you are looking in French recommendation for example, from the French Society of Hygiene, it is also indicated that we need to change every 7 days. But in my opinion, it's not a good, it's a wrong way. And for nurses who are working with patients, it's also difficult for them to change because there is some stress when they are changing the device. So especially when the patient is awake. So my recommendation will be not to change the device if the device works well. It is not clearly contaminated, and it is not is it correctly adherent.
We had exactly the same concern 25 years ago with the duration of catheterization. And we moved despite very few level of evidence. But I think that practically speaking, I think that if your problem is after 7 days, should I change the device? I think you are very happy because it means that your dressing was good at least for 7 days, which is very good. Okay, next question. It's to Corinne. Was the implementation of the QROS the only intervention, and there is a specific question about the hand hygiene compliance during the study period?
The removal of the disinfection wipes and the addition of QROS was the only intervention that we made. Obviously, along with the training that went on how to use it. Yeah, we didn't change anything else.
Okay, and there is another question, a very interesting question. Before the study, did you use sterile wipes or not to clean before using the QROS?
Yeah, yes. They're pre-packaged and they're sterile.
Okay.
Yeah.
And that is the last question. EPICS 3 guidance did not review passive disinfection. How do you approach implementing QROS in the hospital when there is not reviewed in the national guidelines? So it's a very interesting question. Could you do and could you implement something in your bundles if there is no huge evidence in the literature or in the recommendation? What are you thinking about that?
Again, that's why I wanted to do the study, because QROS at the time the EPIC 3 guidelines was done, QROS was only just coming into the country, so it actually missed
the EPIC review, and there isn't going to be another EPIC review for at least 3 years. So from an infection prevention and control point of view, my job is to actually source the best possible products to reduce infection for our patients. And at the end of the day, the EPIC is guidelines. And yes, we introduce those guidelines, but if in your working life you find something that potentially actually goes that little extra mile, and you know that there is a problem, Scrub the Hub is excellent if people do it. But research shows that people don't comply with Scrub the Hub. I could, and I've done it once before, but I could give every single person in this room, without a watch or a clock, I could give you all a needle-free connector and say to you, I want you to scrub this for the allotted time, and then I want you to allow it to dry for the allotted time. And every single one of you would come up with a different timing. And it's literally down to human factor. And if we have something now which actually engineers out that human factor and does a good job for our patients, for their safety and to stop them getting potential bloodstream infections, then to me it's a simple, it's a no-brainer. You just do it. Britain likes, there is, as we said, there's a lot of peer-reviewed studies out there from America, but I know what infection control nurses are like. We like to see British evidence, which is why I wanted to do this work. And there needs to be, there needs to be further work done. But certainly, as I said in the last part of that slide in the conclusion, a small change, big difference. And what's the expression? Simples.
Okay, thank you. I think that most of you are engaged in innovation, and I think that provided you make some surveillance to be sure that you will not be at the end with a worsening situation, I think it's a good idea to try really to make advance in this field. You raise your hand, yeah? Could you go to the microphone, please, because the people at the other part of the room may not hear to you.
It's okay, it's okay.
So you had some national data up on your slides.
Yeah.
Where did you get the national data that you compared your facilities data to?
Okay, the national data is available now on the intranet. The national data was compiled by Vigon with Stephen Rowley, so he helped with the questions, and then they sent out the they sent the questions out to X number of clinical staff, and from that they got the over 1,000 responses.
So part of like ANTT?
Yeah.
And then second question, so you talked about removing the wipes
Yes.
from your floor.
Yeah.
Does that mean that you didn't wipe in between the access? Like, so let's say...
You didn't have to.
You
You don't have to. As soon as, because the Curos is impregnated, this is Spanish, that's impregnated with 70% alcohol, and once you put it on, within 3 minutes, it actually gives you that 5-log kill reduction. When you take it off, you don't even have to allow it to dry. You can access straight away. So it's ideal for hematology oncology patients who are at home. It can actually stay on and for extended period of time. Or if you've got somebody who's being accessed 3 times a day, then you take it off, throw it away, and you put a new one on before you leave the patient once you've actually finished doing what you're doing. Yeah.
Thank you.
You're welcome.
Okay, thank you. Is there questions now from the audience without writing on the cards? It's also possible to stand to go to the microphone. No burning questions? So, we are on time, already on time, and I thank you for attending this session. I thank the speakers for showing us this quite new data. And I thank the sponsor of this symposium, 3M, for having put this program in and for continuing effort and support to us with the technology. Thank you. Have a good afternoon.